Okay, let's dive deep. Imagine for a moment that incredibly alarming symptom, coughing up blood. It's viscerally frightening, isn't it?
Oh, absolutely.
It immediately makes you stop and wonder, how could that possibly happen? Where is that blood coming from?
It is definitely one of the most unsettling symptoms
Yeah.
a patient can experience. And as our source material for this deep dive makes abundantly clear, it demands not just immediate attention, but a really systematic and informed approach to figure out the root cause and, how to manage it.
Absolutely. And that systematic approach, that expert level of understanding, that's precisely our mission today. We're taking a deep dive into a stack of comprehensive medical texts, specifically focusing on two critical interconnected concepts in respiratory and cardiovascular health. Hemoptysis, the medical term for coughing up blood from the
So,
respiratory tract,
mm,
and the body's profound multi-layered response when it's starved of oxygen, a state known as hypoxia.
yeah, these topics are so fundamental to understanding, well, so much about critical illness and chronic conditions. Our goal here is to go beyond just a surface level overview, really extracting the crucial insights and the underlying mechanisms from the sources so you can grasp this material with the kind of detail and nuance that, frankly, distinguishes the truly well-informed professional.
Yeah, getting down to the nuts and bolts.
Exactly. We're going to unpack the why and the how behind these complex physiological events.
We're going straight to the source, pulling out the essential knowledge nuggets that the text emphasize. We'll start by really getting into hemoptysis, what it is, the critical first steps in evaluating it, how we gauge its severity, the anatomy that matters, the incredibly broad range of potential causes, and then the evaluation roadmap and management strategies, especially for the most dangerous cases.
And once we've thoroughly explored the world of hemoptysis, we'll transition to the equally vital topic of hypoxia. We'll explore the fundamental physiological purpose it impacts, and then delve into the body's complex suite of responses to oxygen deprivation, starting right down at the cellular level, looking at how genes are regulated, how different blood vessels react, and the significant effects on major organ systems like the brain and the heart. It's a journey from the microscopic to the systemic.
So let's jump right in. Hemoptysis. At its most basic, what are we talking about?
So as defined by the source material, hemoptysis is the expectoration of blood that originates from the respiratory tract. It means blood that is coughed up is coming from somewhere within the airways or the lung tissue itself. Simple definition, but crucial starting point.
And the sources immediately hammer home one absolutely crucial first step, don't they? You have to figure out if it's actually hemoptysis.
Precisely. Before you even begin to investigate the respiratory system, you must differentiate this bleeding from other sources that might look like it's coughed up. The most common imposters are bleeding from the gastrointestinal tract, that's called hematemesis, often looking like coffee grounds or maybe frank red blood that's vomited, not coughed.
Right, vomited, different mechanism.
Totally different. And the other big one is bleeding from the nasal cavities or nasopharynx, which is epistaxis, the common nosebleed, that then sort of drips back, gets swallowed, and then maybe coughed up. Ruling these out is foundational because the entire diagnostic and management pathway changes dramatically depending on the source.
Okay, so you've confirmed, based on the history or examination, that this blood is coming from the lungs or airways. What's the absolute next most urgent question you need to answer?
Severity. Without a doubt, quantifying the degree of bleeding is paramount. You need to know not just that there's blood, but roughly how much and how often. This immediately stratifies the risk and dictates the urgency of intervention. Is it a speck, or is it something much more significant?
And the source material gives us some very specific thresholds for what counts as massive or life-threatening hemoptysis.
It does, and understanding why these numbers are used is a key insight from the text. Life-threatening hemoptysis is generally defined as coughing up more than 400 milliliters of blood over a 24-hour period, or more than 150 millimils in a single expectoration, like one coughing fit.
Those are quite specific numbers, like you said. Why those exact amounts? Is there a physiological reason?
There is, and this is where the anatomy becomes immediately relevant. The source explains these numbers relate directly to the approximate functional blood volume of the tracheobronchial tree itself, the main airways.
Okay.
That volume is estimated to be around 100 to 200 millivales. So if you're rapidly filling that space with 150 millivales or more of blood, you're essentially overwhelming the system's ability to clear it.
And this brings us to perhaps the single most critical and for many maybe surprising point about the danger of massive hemoptysis that the source emphasizes. The primary risk isn't what you might initially think.
That's absolutely right. When people hear massive bleeding, they often think the danger is bleeding out, losing too much blood volume exsanguination. But the sources highlight that the primary and most immediate risk in massive hemoptysis is actually asphyxiation.
Suffocation, essentially.
Essentially, yes. You're at risk of drowning in your own blood because it fills the airways and the delicate air spaces of the lungs, preventing any oxygen from getting in. And this happens much more quickly than significant volume loss in this specific context. It's about airway compromise, first and foremost.
Wow, that really shifts the entire perspective. It makes complete sense the body is built for air in those spaces, not liquid. But trying to quantify bleeding in milliliters seems almost impossible for a patient who's scared and coughing up blood.
It is, and the sources definitely acknowledge this challenge. Patients almost never can give an accurate volume in ml. So clinically, we often rely on more relatable reference during history taking, asking about the volume in terms of, say, spoonfuls, cups, or even describing things like, did it fill a coffee mug, can help the clinician get a ballpark estimate.
Useful comparisons.
Yeah, and the text helpfully points out that a standard U.S. cup is about 236 milliml, which gives a useful benchmark for that estimation, to translate half a cup into something more concrete.
Okay, so while it's terrifying and potentially life-threatening due to asphyxiation, is massive hemoptysis a common event overall?
Fortunately, no. The source notes that life-threatening hemoptysis is relatively uncommon, accounting for only about 5% to 15% of all cases of hemoptysis. The vast majority fall into the category of non-life-threatening hemoptysis, which still requires thorough evaluation, of course, but typically allows a bit more time for diagnosis.
And for clarity, while we absolutely need to understand the risks and initial management of massive hemoptysis because it's in the source and it's critical, the bulk of the source material we're reviewing really focuses on the evaluation and the incredibly diverse causes of non-life-threatening hemoptysis.
Exactly. That's the clinical scenario you're far more likely to encounter day to day, and the sources provide a really detailed roadmap for navigating that, which is essential for that expert-level understanding we're aiming for.
Right. So to really understand the potential causes, we need to consider the anatomy of the respiratory tract. Where exactly can blood originate from?
Well, technically, bleeding can arise from anywhere in the respiratory tract, starting right up at the vocal cords, the glottis all the way down through the trachea, the main bronchi, the smaller bronchioles, and finally right into the alveoli, those tiny air sacs where gas exchange happens.
But the source identifies certain areas as being, well, more common culprits.
Yes, the sources point to the bronchi, or the medium-sized airways, as the most frequent sites of origin for hemoptysis. However, depending on the specific cause, you can certainly see bleeding from other areas too.
And understanding why bleeding from certain areas is particularly problematic or more common takes us back to the blood supply. The sources mention two distinct circulatory systems serving the lungs and airways. This seems really important.
Oh, this anatomical detail is absolutely fundamental to understanding why hemoptysis behaves the way it does. You have the pulmonary circulation and the bronchial circulation. Two different systems doing different jobs in the same space.
Tell us about the pulmonary circulation first. What's its role?
Okay, so the pulmonary circulation is the low-pressure system. Its main job is gas exchange. It brings deoxygenated blood from the right side of the heart to the capillaries that wrap around the alveoli to pick up oxygen, and then it returns that freshly oxygenated blood to the left side of the heart to be pumped out to the rest of the body. It's high volume, low pressure, all about breathing.
And the bronchial circulation. This seems more relevant to many causes of hemoptysis based on the source.
It absolutely is. The bronchial circulation is different. It originates directly from the aorta, or sometimes intercostal arteries, which means it's part of the high-pressure systemic circulation. These bronchial arteries branch off and primarily supply the tissues of the airways themselves. The bronchi, the supporting connective tissue of the lungs, the lymph nodes, even the visceral pleura.
So it's bringing oxygenated, nutrient-rich blood to the lung structures, not primarily for gas exchange in the alveoli.
Exactly right. It feeds the lung tissue itself. And here's the critical point the source emphasizes. These bronchial arteries can undergo significant neovascularization.
Meaning they grow new vessels.
Yes, forming new, often abnormal and fragile blood vessels in response to chronic inflammation or disease processes. They can proliferate extensively to supply tumors growing in the airways, the thickened, dilated airways seen in conditions like bronchiectasis, and the walls of chronic cavities in the lung, like from TB or fungal infections.
And this neovascularization, supplied by the high-pressure bronchial system, is where a lot of the bleeding comes from, right?
Precisely. The sources clearly state that most hemoptysis, especially significant or massive hemoptysis, originates from the bronchial circulation. And the reason it's often so difficult to stop is directly related to its origin from that higher pressure systemic circulation compared to the low pressure pulmonary system.
It's like trying to plug a leak from a fire hydrant versus a garden hose.
That's a great analogy. Bleeding from a high pressure source is inherently harder to control. This difference in pressure systems and where the bleeding originates is a critical piece of knowledge for anyone wanting to understand hemoptysis like an expert. It dictates management strategies later on.
Okay, so we know where it can come from and why it's potentially dangerous, especially the high-pressure bronchial bleeds. Now, for the big question, what causes it? The sources say the list is varied and broad, and that's certainly an understatement looking at the material.
It truly is remarkably broad, which is exactly why a systematic evaluation is so incredibly important. You can't just guess. The sources group the causes into three main categories to help organize thinking: infection, malignancy, or vascular disease. But the specific conditions within those buckets are numerous.
And where you are in the world makes a big difference in the most likely culprit, doesn't it?
That's a key demographic point highlighted in the source. In the United States and similar industrialized countries, the most common causes today are typically things like viral bronchitis, chronic bronchiectasis, or malignancy. However, globally and historically, infections like tuberculosis remain the leading cause in many regions. So, geographical context, travel history, absolutely vital when evaluating a patient.
Okay, let's dive into the specific causes then. Really unpack this varied list, starting with infections. Viral bronchitis seems like the most common and usually less severe cause.
Yes, the sources point to acute viral bronchitis as a very common cause of just blood-tinged sputum or maybe small volume hemoptysis. It's often just inflammation causing some mild capillary oozing from the airway lining, usually not a big deal on its own.
And what about chronic bronchitis? Can that lead to bacterial issues that cause bleeding?
Absolutely. Patients with chronic bronchitis,
Hmm.
especially those with a history of smoking, are quite susceptible to bacterial superinfections during flare-ups or exacerbations. The sources name common bacteria you'd expect, like Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis.
How does the bacteria cause bleeding?
The mechanism here is basically increased inflammation within the airways caused by the bacteria. This ramps up the irritation and potential for bleeding from the already somewhat damaged airway lining.
Bronchiectasis comes up repeatedly in the sources as a really significant cause, even of massive bleeding.
Bronchiectasis is indeed a major player, particularly when you're talking about recurrent or even massive hemoptysis. Patients with this condition have chronically dilated and damaged airways, often resulting from previous severe infections like childhood pneumonia or TB. These airways aren't just damaged, they're chronically inflamed and, crucially, become highly vascularized by those high-pressure bronchial arteries we talked about, precisely because of the chronic infection and inflammation.
And you mentioned earlier there's a specific, rather stark finding about bronchiectasis in the sources regarding massive bleeding.
Yes, this is a critical takeaway for anyone dealing with hemoptysis. Several case series cited in the sources identify bronchiectasis as the leading cause of massive hemoptysis and subsequent death in those series. That single fact really underscores the importance of identifying and properly managing this condition in patients presenting with hemoptysis. It's not a benign condition when it comes to bleeding risk.
Tuberculosis, while less common maybe in industrialized countries now compared to the past, is still historically and globally incredibly significant. Where does the bleeding typically come from in TB?
Historically, TB was the scourge associated with hemoptysis worldwide. While rates have certainly decreased in some areas thanks to treatment and control, it remains a major cause globally. The source of bleeding in TB is frequently related to cavitary disease, the formation of holes or cavities in the lung tissue as the bacteria destroy it. Blood vessels, often branches of the pulmonary artery, can run along the walls of these cavities and are vulnerable to erosion by the ongoing inflammation and necrosis.
Is there a specific named complication related to that?
Yes, a particularly dangerous, albeit rarer, complication mentioned in the source is the erosion of a pulmonary artery aneurysm, a weakened bulge in the vessel wall directly into a cavity. This is sometimes specifically called a Rasmussen's aneurysm, and it can cause sudden catastrophic massive bleeding.
Wow. Are there other less common infections that can cause hemoptysis, maybe similar chronic lung damage?
Yes, the differential definitely continues with other infections that cause chronic lung problems. Endemic fungi like histoplasma or coccidioids, which are common in certain geographic areas, nocardia bacteria, and non-tuberculous mycobacteria like MC, Mycobacterium avium complex. These can all cause chronic cavitary lung disease that looks a bit like TB and can be complicated by bleeding for similar reasons.
And what about aspergillus? That comes up too.
Right, Aspergillus species are important here. In patients who have pre-existing cavities in their lungs, from old TB for example, Aspergillus can sometimes colonize that space and form a fungal ball, which is called a mycetoma. The tissue surrounding the mycetoma is often chronically inflamed and highly neovascularized, again, often by those bronchial arteries, making it a really significant potential source of bleeding, sometimes quite severe.
What about infections that essentially destroy lung tissue more acutely?
Pulmonary abscesses and necrotizing pneumonia fall into this category. These are severe infections that cause bleeding by actually devitalizing or killing off the lung parenchyma, including the blood vessels within it. Common organisms responsible, according to the sources, include bacteria like Staphylococcus aureus, Klebsiella pneumonia, and often mixed oral anaerobes, especially in cases related to aspiration pneumonia.
The sources also mention a parasitic cause that's significant globally, though maybe less common here.
Paragangliomyces. Yes, this is a trematode or fluke infection. It's common in parts of Southeast Asia and China, and it can cause lung lesions that mimic TB or cancer and frequently present with hemoptysis, sometimes described as rusty sputum. The sources note cases have occurred in North America related to consuming raw or undercooked crayfish, which carry the parasite.
So again, travel history or dietary history can be key.
Absolutely critical. This is a reminder that you have to think broadly based on the patient's exposures and background. You can't just assume it's the most common local cause.
That covers a lot of ground on the infectious front. Let's move to the vascular causes, which can also be quite complex. Cardiac disease seems like an unusual suspect for coughing up blood.
It might seem counterintuitive at first glance, but certain cardiac conditions can indeed lead to hemoptysis. The primary mechanism described in the sources is related to pulmonary edema, resulting from elevated pressure in the left side of the heart, specifically elevated left end diastolic pressure, which typically happens in heart failure. This back pressure gets transmitted into the pulmonary capillaries.
I thought pulmonary edema mainly caused that classic pink and frothy sputum description.
That is the classic description, often taught, and the sources certainly mention it. However, they clarify that the presentation can actually range along a spectrum from that pink frothy sputum all the way to frank hemoptysis with red blood and even clots. This is particularly true, the sources note, in patients who are taking anticoagulant or antiplatelet medications, which makes those fragile, congested capillaries more likely to rupture. And so many cardiac patients are on these meds.
Right, that makes sense. What about blood clots in the lungs, pulmonary embolisms, or PEs? Can they cause hemoptysis?
A pulmonary embolism can cause hemoptysis, specifically if the clot is large enough or peripheral enough to cause pulmonary infarction, basically, tissue death in a portion of the lung because its blood supply got cut off by the clot. Bleeding can occur from that infarcted tissue. However, the sources make a point to note that PEs do not commonly cause hemoptysis overall. It's a possible presentation, but less frequent than symptoms like sudden shortness of breath or pleuritic chest pain.
Are there issues with just abnormally formed or fragile blood vessels within the lungs themselves?
Yes, definitely.
Yeah.
Sources of bleeding can include things like ectatic vessels, which are just abnormally widened, tortuous small blood vessels, sometimes seen in the airways, or more complex pulmonary arteriovenous malformations, AVMs. These AVMs are abnormal direct connections between pulmonary arteries and veins bypassing the capillaries, and these thin-walled structures can rupture and bleed, sometimes significantly.
And then there's a rare but extremely dangerous vascular cause mentioned that sounds quite dramatic.
Ah, the aortobronchial fistula. Yes. This is a rare but potentially catastrophic cause of hemoptysis. It's exactly what it sounds like. An abnormal connection, a tunnel basically, that forms between the aorta, the body's main artery, and a bronchus, an airway. This usually arises in the setting of severe aortic pathology, like an aortic aneurysm or a pseudoaneurysm, maybe after surgery or infection.
And the danger is?
The danger is immense because these fistulas can cause small, seemingly minor bleeds, initially just a bit of the hemoptysis that might get dismissed. But these are often sentinel bleeds, a warning sign heralding a massive, potentially fatal hemorrhage that can occur suddenly. And without further warning and the connection fully ruptures, it's a true vascular emergency.
Diffuse alveolar hemorrhage, or DAH, is another vascular-related condition mentioned in the sources. Now, this sounds like it must cause hemoptysis, right? It's literally bleeding into the lung tissue itself.
You'd absolutely think so, wouldn't you? DAH involves widespread bleeding directly into the tiny air sacs, the alveoli throughout the lungs. It's diffuse, meaning all over. But here's that counterintuitive point the sources make quite clearly. DAH is not often associated with significant hemoptysis despite the substantial internal bleeding. Patients might have some blood-tinged sputum, but often they present more with shortness of breath, low oxygen levels, and characteristic changes on imaging.
How would DAH typically present on imaging if not necessarily with lots of coughing up blood?
On chest imaging, like a CT scan, DAH typically presents with diffuse, often bilateral ground glass opacities or sometimes consolidation throughout the lungs. This hazy appearance reflects the blood filling the air spaces where air should be.
And what causes DAH? Is it one specific thing or multiple possibilities?
The sources list a pretty broad range of underlying causes for DAH. These include immune-mediated conditions that cause capillaritis inflammation and damage of the tiny capillaries in the lung walls. This is often seen in systemic autoimmune diseases like systemic lupus erythematosus, SLE, or vasculitis syndromes. Toxicity from inhaled substances, like certain drugs or chemicals, can also trigger it.
And there are specific pulmonary renal syndromes mentioned. Those sound particularly relevant.
Yes, this is a particularly important category to be aware of. Diseases that affect both the lungs and the kidneys simultaneously, such as granulomatosis with polyangiitis, formerly Wegener's, and antiglomerular basement membrane disease, also known as Goodpasture syndrome, are classic causes of DAH. The sources note that patients with these conditions may present with both hemoptysis, from lung involvement, and hematuria, which is blood in the urine, from kidney involvement. But critically, one can be present without the other, so you can have DAH without obvious kidney problems initially, or vice versa.
And there's a very recent addition to the list of DAH causes highlighted in the sources, reflecting current public health issues, unfortunately.
Yes, and it's important to note this. Vaping-induced lung injury, sometimes called EVALI, has recently been identified as a cause of both hemoptysis and diffuse alveolar hemorrhage. This really underscores how important it is for clinicians to stay updated on new potential exposures and their pulmonary manifestations as the causes of lung injury evolve.
All right, let's move on to malignancy as a cause of hemoptysis. Lung cancer seems like an obvious one here.
It is, unfortunately. The sources state clearly that bronchogenic carcinoma lung cancer originating in the airways is a common cause of hemoptysis, and this applies to pretty much any histological type of lung cancer, whether it's squamous cell, adenocarcinoma, or others. It can cause both minor and massive bleeding.
How exactly does the lung cancer cause bleeding? Is it just growing through things?
Often, yes. Hemoptysis in this context usually indicates that the tumor is growing into or irritating an airway, causing ulceration of the surface, or perhaps it's eroding into nearby blood vessels, either the bronchial arteries supplying the tumor itself or adjacent pulmonary vessels. Its location and invasiveness are key.
Are there other types of tumors that grow in the lungs that can bleed?
Yes, carcinoid tumors are specifically mentioned. These are neuroendocrine tumors that often arise in the larger, more central airways. They tend to be quite vascular, lots of blood vessels, and so they can frequently present with hemoptysis, sometimes as the first symptom.
And certain types of lung cancer are more likely to cause massive, life-threatening bleeding.
That's an important distinction the sources make, relating back to anatomy. Small cell lung cancer and squamous cell carcinoma have a tendency to develop more centrally in the lung, near the major airways, and large pulmonary vessels close to the hilum. This anatomical location makes them statistically more likely to erode directly into major pulmonary vessels, which, as we discussed, can lead to massive, difficult-to-control hemoptysis compared to tumors located more peripherally in the lung.
What about cancer that started somewhere else in the body and then spread to the lungs? Can that cause bleeding?
Yes, absolutely. Pulmonary metastasis cancer that is spread from a distant primary site, like the colon, breast, kidney, or melanoma, for example, to the lungs can also cause bleeding. If these metastatic deposits are located near or invade into airways or blood vessels within the lung, they can certainly cause hemoptysis.
And there's a specific type of malignancy mentioned that's particularly seen in patients with advanced HIV infection.
Kaposi's sarcoma, yes. The sources describe this as a vascular malignancy that is often seen in patients with advanced acquired immunodeficiency syndrome, AIDS. These KS lesions are characteristically very vascular, reddish-purple lesions, and they can develop anywhere along the respiratory tract, from the lining of the mouth and upper airways down into the trachea and bronchi. Because they are so vascular, they can be a significant source of hemoptysis in affected patients.
Okay, we've covered a huge range: infectious, vascular, and malignant causes. What about mechanical issues or other miscellaneous causes listed in the sources?
The sources include a few other interesting categories. One is pulmonary endometriosis. This is a less common but fascinating cause where endometrial tissue, the tissue that normally lines the uterus, implants and grows somewhere in the lung or airways. This tissue responds to hormonal cycles, leading to cyclical bleeding that occurs around the time of the menstrual period. This is known as catamenial hemoptysis.
Wow, that's specific. Foreign body aspiration makes intuitive sense as a cause of bleeding, I suppose?
Absolutely. Inhaling a foreign object, particularly into the airways, think a peanut in a child, or maybe a piece of food in an adult with swallowing difficulties can cause direct mechanical irritation, abrasion of the airway lining, or inflammation that leads directly to bleeding.
And sometimes the very medical procedures intended to help can inadvertently cause hemoptysis.
Unfortunately, yes, iatrogenic causes are possible. Diagnostic and therapeutic procedures themselves can sometimes be the source. The sources mention pulmonary vein stenosis, which is a narrowing of the pulmonary veins, sometimes occurring as a complication after procedures in the left atrium, like pulmonary vein isolation for treating atrial fibrillation. This stenosis can increase pressure upstream and potentially lead to bleeding.
Any other procedure risks?
A more dramatic, though thankfully rare, procedural complication mentioned is rupture of the pulmonary artery. This can happen if a pulmonary artery catheter, often called a Swan-Ganz catheter, is advanced too far into a small vessel, and the distal balloon is inflated, causing the vessel wall to tear. That leads to sudden, often massive hemoptysis.
Finally, what if a patient just has a problem with their blood's ability to clot normally?
This is a critical modifying factor, or sometimes even the primary driver. The sources explain that in patients with an underlying bleeding diathesis, meaning a tendency to bleed more easily than normal, even minor insults to the airway lining or small, otherwise insignificant vascular lesions can result in significant hemoptysis.
What conditions fall under bleeding diathesis?
This includes conditions like thrombocytopenia, having a low platelet count, inherited coagulopathies like hemophilia, acquired coagulopathies often due to liver disease, or, very importantly and commonly these days, patients who are on therapeutic anticoagulation, like warfarin or the newer DOACs, or antiplatelet therapy, like aspirin or clopidogrel. These medications intentionally impair clotting and therefore lower the threshold for bleeding from any potential source, including the lungs.
Just running through that incredible list of causes, infections, vascular problems, cancers, mechanical issues, bleeding disorders, really drives home why the sources describe the differential diagnosis as varied and broad. It requires a truly systematic approach to sort through.
It absolutely does, and that systematic approach to evaluation and management is precisely what the sources outline next. You need a framework to tackle this complexity effectively.
So let's walk through that framework. Based on the source material, what are the key components of the evaluation when someone presents with hemoptysis?
Okay, the evaluation logically starts with a thorough history, really building on everything we just discussed about the potential causes. You absolutely need to quantify the severity as best you can, asking about flecks, streaks, teaspoonfuls, cups, frank blood versus clots. Get details about the onset, sudden or gradual, duration, frequency. Then you dive into the risk factors, extensive smoking history, occupational exposures like silica or asbestos, history of past infections, particularly TB or known fungal infections, any recent travel history, especially to endemic areas, known chronic lung diseases like bronchiectasis or COPD, any history of cancer, known heart problems, kidney problems, any autoimmune conditions. And crucially, review all medications, especially asking specifically about anticoagulants or antiplatelet agents.
A lot to cover there. What about the physical examination? What are you looking for?
The physical exam is vital too. You start always with vital signs, which are critical, especially if you suspect massive hemoptysis. Assess oxygen saturation for hypoxemia, check heart rate for tachycardia, blood pressure for hypotension. Any signs of hemodynamic instability need immediate attention. Then, visually inspect the nasal passages and the oral cavity, carefully to rule out those other potential sources. Look for active bleeding from the nose, epistaxis, or signs that blood might be coming from the GI tract, hematemesis.
And listening to the lungs.
Absolutely. Listen carefully to the lungs with a stethoscope, auscultation. Sometimes you might hear crackles, which could indicate fluid or blood in the air spaces, or maybe even a focal wheeze, which could suggest a localized airway lesion or an aspirated foreign body blocking an airway. You also look for other clues peripherally. Clubbing of the fingers might suggest chronic lung disease or malignancy. Look for signs of systemic disease or evidence of a bleeding diathesis elsewhere on the body. Check the skin and mucous membranes for bruising, ecchymosis, petechiae, small red spots, or telangiectasias, dilated small vessels.
Okay, history and physical done. What are the initial diagnostic studies the sources recommend for virtually every patient presenting with hemoptysis?
The standard initial lab tests usually include a complete blood count, CBC. This checks for anemia from blood loss, a high white blood cell count suggesting infection, and importantly, the platelet count to look for thrombocytopenia. Coagulation parameters like PTINR and PTT are essential, especially if the patient is on anticoagulants, has known liver disease, or if you suspect a coagulopathy. Basic electrolytes and renal function tests like creatinine are needed to assess kidney function. And the sources state that a urinalysis is important to help screen for those pulmonary renal syndromes we discussed earlier, looking for blood or protein in the urine.
And imaging is basically non-negotiable, right? You have to look inside.
Absolutely. The sources are very firm on this point. Chest imaging is necessary for every patient presenting with hemoptysis. You simply cannot adequately evaluate hemoptysis without getting a picture of the lungs and airways.
The initial image is usually a standard chest X-ray, or CXR.
Yes, a standard posterior, anterior, and lateral chest X-ray is typically the first imaging step. It's readily available and gives a good overview. However, and this is important, the sources caution strongly about its limitations in this context. A CXR often does not precisely localize the site of bleeding, and quite frequently it can appear completely normal, or maybe show only nonspecific changes, even when there's a significant underlying problem like a small tumor or bronchiectasis causing the hemoptysis.
So if the CXR isn't always enough, or might even be normal, where do you go from there? The sources seem to outline a kind of branching approach based on the patient's risk factors.
Exactly. This is a key decision point in the evaluation pathway described in the sources. If a patient has a normal chest radiograph and they have no significant risk factors for malignancy, like age over 40, significant smoking history, or other serious abnormalities identified in that initial history, physical, and lab workup.
The low-risk patient?
Right, the low-risk patient. In this specific setting, the sources suggest that a less aggressive approach initially may be reasonable. This might involve treating symptomatically, perhaps for presumed bronchitis, and ensuring very close clinical follow-up. Further diagnostic workup, like a CT scan, would then only be pursued if the hemoptysis persists, recurs, or worsens.
But what if there are risk factors for malignancy, like being over 40 or having that significant smoking history, or if the CXR shows something abnormal?
Then the pathway changes significantly. Patients who fall into these higher risk categories should undergo additional, more detailed testing, regardless of the initial CXR findings sometimes. The next step is almost always a chest-computed tomography, CT scan, usually performed with intravenous contrast material.
Why CT? What does it add?
The sources explain that CT provides much higher resolution imaging compared to a plain X-ray. It's far better at identifying small masses or nodules, detecting and characterizing the extent of bronchiectasis, those dilated airways, and revealing subtle parenchymal lesions or vascular abnormalities that a CXR might completely miss. The contrast helps visualize blood vessels and differentiate tissues.
And if you're specifically concerned about a blood clot, a PE as the cause?
If the clinical picture of the patient's symptoms like sudden onset shortness of breath, pleuritic pain, maybe risk factors like recent surgery or immobility raises suspicion for a pulmonary embolism, the sources mention that a specific type of CT scan protocol, a CT pulmonary angiography or CTPA, should be considered. This is specifically designed to visualize the pulmonary arteries and look for clots within them.
Okay, so for the higher risk patient, CT is usually next. After the CT scan in those patients, particularly those with malignancy risk factors, what's the next recommended step if the CT doesn't give a clear answer?
If the CT scan in a patient with malignancy risk factors doesn't clearly reveal a definite diagnosis, or perhaps shows an abnormality like airway thickening or a nonspecific opacity that needs direct visualization, then flexible bronchoscopy should generally be performed next.
And the goal of bronchoscopy here is?
The primary purpose here is to directly visualize the airways using a thin, flexible camera scope. You can look for an endobronchial lesion, a growth inside the airway itself, which might be missed on CT, assess the airway lining, take biopsies or brushings for cytology, and essentially try to exclude bronchogenic carcinoma, especially if the CT didn't show a clear peripheral mass that could be easily biopsied using CT guidance instead.
Is bronchoscopy always successful in finding the exact source of bleeding, though?
That's a good question, and the sources acknowledge this challenge. While bronchoscopy can often be very helpful in identifying which side the bleeding is coming from, which is important information, it actually only has about a 50% chance, according to the data cited, of pinpointing the exact bleeding site or the specific lesion responsible. This is particularly true if the bleeding is intermittent or if it's originating from smaller, more peripheral airways beyond the reach of the standard flexible scope.
And there seems to be some clinical debate or nuance mentioned about the timing of bronchoscopy, especially when someone is actively bleeding heavily.
Yes, the sources do note that there is some expert disagreement on the optimal timing of flexible bronchoscopy, particularly in the setting of massive hemoptysis, where time is critical and visualization might be obscured by blood. And in certain specific conditions, like severe cystic fibrosis, where massive bleeds can occur from bronchiectasis, bronchoscopy might actually be not recommended by some experts during active bleeding because it could potentially delay more definitive interventions like bronchial artery embolization and might even worsen bleeding in some cases.
Given that difficulty in precisely locating the bleeding site, especially in urgent situations, is there an alternative initial diagnostic and therapeutic strategy mentioned in the sources, maybe bypassing bronchoscopy initially?
Yes, particularly for massive hemoptysis. The sources suggest that proceeding directly to angiography, specifically with the intent of performing bronchial artery embolization, which we'll discuss more, is a reasonable strategy in cases of massive hemoptysis or when rapid localization and intervention are paramount. The thinking is that angiography can both potentially diagnose by showing contrast leaking from a vessel and treat by blocking that vessel in the same procedure, which can save crucial time compared to doing bronchoscopy first, maybe not finding the site and then going to angiography.
That makes a lot of sense in an emergency. Speaking of urgent intervention, let's shift fully now to the management of a massive or life-threatening hemoptysis. This is clearly a medical emergency requiring immediate action.
It absolutely is. The sources highlight the extreme urgency and outline three simultaneous critical goals when managing massive hemoptysis. You have to think about and act on all three at once. First and foremost, protect the non-bleeding lung. Second, try to locate the site of bleeding. And third, control the bleeding. Failure on that first point, protecting the airway and the good lung, is often the most immediate cause of death due to that asphyxiation risk we stressed earlier.
Protecting the airway and the healthy lungs seems paramount then, tying right back to the asphyxiation risk. How do you do that?
It is the absolute top priority initially. Asphyxiation can happen incredibly rapidly when airways fill with blood. The sources provide specific tactics. If you can determine even roughly which side the bleeding is coming from, maybe based on patient sensation, exam findings, or a quick x-ray, the patient should be immediately positioned with that bleeding side down. It's simple gravity. It helps keep the blood contained in the affected lung and prevents it from spilling over into and blocking the healthy non-bleeding lung.
That makes sense. What about intubation? Putting a breathing tube in, is that always needed right away in massive hemoptysis?
Surprisingly, maybe, the sources advise some caution with routine immediate endotracheal intubation, unless it's absolutely necessary to secure the airway, e.g. the patient is losing consciousness, tiring out, or clearly can't handle secretions. The reason given is that a patient's own vigorous cough reflex is often actually more effective at clearing blood and clots from the large airways than suctioning through a relatively narrow standard endotracheal tube. If the patient is conscious and can maintain their own airway and cough effectively, intubating them might paradoxically hinder their ability to clear the blood.
But if intubation is required because the airway is compromised or they simply can't protect it anymore?
If intubation becomes unavoidable, then you need a specific strategy to try and protect that non-bleeding lung during and after the procedure. This isn't just standard intubation. The sources mention options like selectively intubating only the main bronchus of the healthy non-bleeding lung with a standard endotracheal tube, pushing it down one side, or, more ideally, if available and expertise exists, using a specialized double-lumen endotracheal tube. This tube has two separate channels and cuffs, allowing for independent ventilation of each lung and complete isolation of the bleeding side from the non-bleeding side. These are advanced airway techniques requiring specific training.
Okay, airway protected. Now, locating the bleeding site in an emergency setting still sounds incredibly challenging. We know flexible bronchoscopy only finds it about half the time, maybe less if there's tons of blood.
It is frequently difficult, no doubt, though sometimes the source is visually obvious if it's a large tumor bleeding right in the main airway. A chest x-ray might give a clue about which side has new opacity suggesting blood, but as we said, it's not sufficient for precise localization in this urgent setting. CT angiography, if the patient is stable enough to get scanned, can be very helpful by visualizing active contrast extravasation, seeing where the dye is leaking out.
And bronchoscopy's role here.
Flexible bronchoscopy, if performed, might be useful primarily to confirm the site of bleeding, which is critical information for directing interventions like embolization or surgery. But again, the sources note its limited success in pinpointing the exact site, and the debate about its use versus potential delay in the most severe active bleeds remains.
So, if speed and definitive localization are issues, that really reinforces why angiography might be preferred as an early step.
Exactly. The sources present proceeding directly to angiography as a very reasonable initial strategy for managing massive hemoptysis, precisely because, unlike bronchoscopy alone, angiography offers the potential to both diagnose, by locating the bleeding vessel, usually a bronchial artery, and treat via embolization in the same session. This combined diagnostic therapeutic capability can save crucial time when the patient is actively bleeding.
Which brings us neatly to actually controlling the bleeding itself. What are the main intervention strategies outlined in the sources once you've protected the airway and have an idea of where to target?
There are essentially three main approaches described for controlling severe hemoptysis. First, measures performed from within the airway lumen, usually via bronchoscopy. Second, measures targeting the involved blood vessel from the outside, primarily embolization. And third, surgical resection of the bleeding lung tissue.
Let's start with the bronchoscopic measures performed through the airway. Are these usually definitive?
These are generally described in the sources as temporizing measures, meaning they're designed to buy time, slow the bleeding, or provide temporary control, rather than being a definitive cure in most cases of massive bleeding. Using a flexible bronchoscope, an operator can suction out blood and clot to clear the airway as much as possible. They can also sometimes deploy temporary devices like an inflatable balloon catheter or a bronchial blocker like a plug to physically occlude or block off the specific airway segment that seems to be leading to the bleeding site.
Is rigid bronchoscopy different?
Yes, rigid bronchoscopy, which uses a larger metal tube and is usually performed by interventional pulmonologists or thoracic surgeons under general anesthesia, offers a more stable platform. It allows for better suctioning of large clots and can facilitate direct therapeutic interventions on visible airway lesions, things like using electrocautery or laser photocoagulation to try and stop bleeding from a tumor surface or vessel within the airway wall. But again, often temporizing for massive bleeds originating deeper.
Okay, so bronchoscopic measures are often temporary. The second approach targets the vessel itself, and you mentioned this is considered the procedure of choice for most massive hemoptysis.
Yes, bronchial artery embolization, or BAE, is widely regarded as the go-to first-line interventional procedure for controlling massive hemoptysis. This is because the vast majority of significant bleeding, as we established, originates from those high-pressure bronchial arteries. BAE is an interventional radiology procedure.
How does it work?
They use angiography, real-time X-ray imaging with contrast dye to guide a very thin catheter, usually inserted via an artery in the groin, up into the aorta and then selectively into the bronchial arteries supplying the lungs. Once they identify the abnormal bleeding vessel, sometimes they see active contrast leaks, sometimes just abnormal vessels going to the diseased area, they inject tiny embolic agents. These could be small particles, microspheres, glue, or tiny metal coils directly into that vessel to block it off, essentially creating an internal clot and stopping the blood flow to the bleeding site.
Sounds effective, but are there risks involved with blocking off those arteries?
Yes, while generally safe and highly effective when performed by experienced interventional radiologists, there are potential significant complications. The sources specifically mention the risk of inadvertent non-target embolization. The most feared complication is accidentally blocking the anterior spinal artery, which sometimes originates near the bronchial arteries and supplies the spinal cord. Blocking this can, in rare cases, lead to paralysis, paraplegia. Other risks include chest pain or difficulty swallowing if other nearby arteries are affected.
But if successful, it stops the bleeding quickly.
Yes, BAE is generally very effective in achieving immediate control of the bleeding in the short term. The sources cite success rates typically greater than 80% for immediate hemostasis. However, and this is a crucial point emphasized in the text, bleeding can recur later on, sometimes weeks or months later. This recurrence happens particularly if the underlying disease that caused the abnormal vessel growth and bleeding, like an untreated mycetoma, active TB, or progressing bronchiectasis, is not addressed definitively. Embolization stops the current bleed from that specific vessel, but it doesn't necessarily cure the underlying lung disease that's driving the problem. New vessels can grow back.
That makes sense.
So what's the third and final approach mentioned? Surgical resection. This sounds like the most drastic measure. It absolutely is. Surgical resection involves an operation to physically remove the portion of the lung, like a lobe or a segment, or the section of airway that is identified as the source of the bleeding. This is generally considered a measure of last resort, primarily because of the significant risks involved, especially in patients who are already critically ill from massive bleeding.
How high are the risks?
The sources note a disturbingly high mortality rate associated with emergency surgical resection for massive hemoptysis, with estimates ranging from 15% up to 40% in some series. This reflects both the critical condition of these patients undergoing major surgery and the technical challenges of operating on inflamed, bleeding lung tissue.
So, when is surgery actually considered the right option?
Given the high risks, the sources state that surgical resection should generally only be pursued if initial, less invasive measures like bronchial artery embolization have failed to control the bleeding or are not technically feasible, and the severe bleeding is ongoing and life-threatening. The ideal candidates for surgery, if it comes to that, are typically those patients who have localized disease, meaning the source of the bleeding is clearly confined to a specific anatomically resectable part of the lung, and who, importantly, otherwise have relatively normal lung function in the remaining lung tissue they'll be left with after the surgery.
Right.
You wouldn't typically consider it for diffuse disease like widespread bronchiectasis.
That is an incredibly comprehensive deep dive into hemoptysis, really covering everything from its basic definition, that critical distinction between the danger of asphyxiation versus acanguination, the key anatomical point about the two different circulatory systems, that vast array of causes, from simple infections to complex vascular issues and cancers, and then the very systematic evaluation and urgent management strategies needed. It really paints a full picture.
It truly covers the essential knowledge base required to approach this complex and often frightening symptom with the understanding of an elite professional, drawing directly from the detailed information laid out in the sources. It's about knowing the why behind the what.
Okay, we've spent considerable time really unpacking the intricacies of hemoptysis. Let's transition now to our second major topic for this deep dive, hypoxia. We've touched on how conditions like massive hemoptysis can lead to a lack of oxygen by physically blocking the airways. But let's zoom out now. What exactly happens throughout the body physiologically when it's deprived of sufficient oxygen for any reason?
Right, this takes us back to the most fundamental purpose of the entire cardiorespiratory system itself. Its absolute core function, as the sources remind us, is to ensure that every single cell in the body receives an adequate supply of oxygen and nutrients, while simultaneously removing the waste products of metabolism, primarily carbon dioxide. It's the delivery and pickup service for life.
And achieving that vital function depends on a number of things working together perfectly, almost like a finely tuned machine.
Precisely. As the sources highlight, this critical function relies on having intact, properly working cardiovascular and respiratory systems, the pump and the bellows, if you will. But it also depends crucially on having enough red blood cells and functional hemoglobin within those cells to actually bind and transport the oxygen from the lungs to the tissues. And of course, it relies on having a sufficient concentration of oxygen in the inspired gas, the air you breathe in the first place. Hypoxia is essentially the state where there is inadequate oxygen availability at the tissue level to meet the metabolic demands, potentially failing in one or more of those essential components.
So what is the immediate impact right down at the level of the individual cell when oxygen levels drop? What's the first thing that goes wrong?
The immediate consequence within the cell when oxygen availability decreases is the inhibition of oxidative phosphorylation. This is the incredibly efficient process that normally happens inside the mitochondria, using oxygen as the final electron acceptor to generate the vast majority of the cell's energy currency, ATP. No oxygen, no efficient ATP production.
And if that primary energy pathway is blocked or severely limited, what does the cell do?
The cell desperately attempts to compensate by ramping up a much less efficient backup pathway, anaerobic glycolysis. This process can generate a small amount of ATP by breaking down glucose without needing oxygen. The sources mention this increase in glycolysis in the presence of oxygen limitation is sometimes referred to historically as the Pasteur effect.
But it's much less efficient at making energy, right?
Significantly less efficient. The net result of relying primarily on anaerobic glycolysis is a drastically reduced rate of ATP production compared to when oxygen is abundant and oxidative phosphorylation is humming along. You get maybe 2 ATP per glucose instead of around 30-something. It's a huge drop-off.
And what happens in severe or prolonged hypoxia when even that backup system can't keep up?
In severe hypoxia, the dramatically reduced ATP production eventually becomes inadequate to power the essential cellular machinery, particularly the ion pumps embedded in the cell membrane that maintain the crucial ionic and osmotic balance between the inside and outside of the cell, like the sodium-potassium pump. When these pumps fail due to lack of energy,
Uh-oh.
the cell membrane starts to lose its normal electrical potential. It depolarizes.
What happens when the membrane depolarizes like that?
This depolarization triggers the opening of voltage-gated calcium channels in the membrane, leading to an uncontrolled excessive influx of calcium ions, Ca2+, from outside the cell into the cell's interior, the cytoplasm. This sudden surge of intracellular calcium is a major trigger for cellular damage.
How does the excess calcium cause damage?
It acts like a wrecking ball. This excessive intracellular calcium activates various calcium-dependent destructive enzymes. The sources mention phospholipases, which start breaking down the lipids in the cell membranes, and proteases, which start breaking down essential cellular proteins.
And that cascade leads inevitably to cell damage and death.
Yes, this toxic cascade of events, membrane damage, protein breakdown, plus the osmotic stress from failing ion pumps leads to cell swelling as water rushes in, activation of internal pathways that trigger programmed cell death, apoptosis, and ultimately, if the hypoxia is severe enough and not corrected quickly, irreversible cell injury and death. So at its core, hypoxia directly compromises the very energy production and structural integrity that cells need just to survive and function.
That's the immediate acute damage pathway, a real cellular crisis. But the body also has mechanisms to try and adapt to lower oxygen levels, doesn't it? Particularly if the hypoxia is maybe less severe or more chronic, like living at high altitude.
It absolutely does. The body isn't just passive, it mounts adaptive responses to hypoxia. And the sources explain that a key part of this adaptation involves changes in gene expression, actively turning certain genes on or off to help the organism cope better with the low oxygen environment.
And is there a central player, a master switch perhaps, that triggers these genetic adaptations in response to low oxygen?
Absolutely. The sources highlight a crucial molecule here, a hypoxia-sensitive transcription factor known as hypoxia-inducible factor 1, or HIF1 for short. Think of HIF1 as a molecular oxygen sensor within cells. When oxygen levels are normal, HIF1 is usually kept at low levels and rapidly degraded. But when oxygen is low, hypoxic conditions, HIF1 becomes stabilized and active. Then moves into the cell nucleus, binds to specific DNA sequences called hypoxia response elements, HREs, and effectively turns on a whole set of specific genes designed to help the cell and the body survive hypoxia.
That's fascinating. What kind of genes does HIF1 activate? What proteins do they make that help the body cope with low oxygen?
HIF1 activation increases the expression of a whole suite of proteins designed to improve energy production under low oxygen and enhance oxygen delivery. The sources give several key examples. It upregulates various glycolytic enzymes like phosphoglyceric kinase and phosphofructokinase to boost the efficiency of that anaerobic glycolysis pathway we talked about. It also increases the production of glucose transporters, such as GLUT1 and GLUT2 embedded in the cell membrane, to make sure the cells can pull in enough glucose fuel to run that less efficient pathway.
So, boosting the backup energy system, does it also help improve oxygen delivery itself?
Yes, critically it does. HIF1 also drives the increased expression of important growth factors that are vital for enhancing the body's oxygen delivery capacity over the medium to longer term. This includes vascular endothelial growth factor, or VEGF, which is a powerful signal stimulating the formation of new blood vessels, angiogenesis, to improve blood flow and oxygen supply to tissues that need it. And perhaps most famously, HIF1 upregulates the gene for erythropoietin, EPO, the hormone produced mainly by the kidneys that acts on the bone marrow to stimulate the production of more red blood cells, thereby increasing the blood's overall oxygen carrying capacity. These are really powerful fundamental adaptations, all orchestrated largely by that single molecular sensor, HIF1.
So we have the immediate cellular crisis response and then these longer-term genetic adaptations mediated by HIF1. What happens in the vascular system itself, the blood vessels in response to hypoxia? This seems particularly interesting given our earlier discussion about the different bronchial and pulmonary circulations in hemoptysis.
This is where things get truly fascinating and a bit paradoxical, because the response of blood vessels to hypoxia is dramatically different depending on where that blood vessel is located in the body. It's not a uniform response at all.
Okay, tell me more. How do systemic vessels react?
The sources explain that in systemic arterioles, the small arteries supplying blood to tissues throughout the rest of the body, like muscles, skin, brain, mostly hypoxia, typically causes them to dilate or widen. It's called hypoxic vasodilation.
Why would the systemic vessels widen when oxygen is low? What's the benefit?
The adaptive benefit is thought to be to try and increase blood flow to those tissues to compensate for the lower oxygen content in the blood, attempting to maintain adequate oxygen delivery despite the systemic hypoxia. The exact mechanism is complex and still debated, but the sources suggest it's at least partly due to the opening of specific ion channels in the smooth muscle cells of the vessel walls, called ATP-sensitive potassium, KATP channels. The idea is that the reduction in cellular ATP concentration during hypoxia triggers these channels to open, leading to hyperpolarization and relaxation of the muscle, causing the vessel to dilate.
Okay, so systemic vessels open up to try and get more flow, but you said the response in the pulmonary circulation, the lungs, is completely opposite.
It is. In striking contrast to almost everywhere else in the body, hypoxia causes the vascular smooth muscle cells in the pulmonary blood vessels, the arterial supplying the alveoli, to constrict or narrow. This unique response is termed hypoxic pulmonary vasoconstriction, or HPV.
And the mechanism driving this constriction is different too.
Yes. The sources detail a distinct intracellular signaling mechanism. In pulmonary artery smooth muscle cells, hypoxia seems to inhibit certain types of potassium K+ channels. This inhibition leads to depolarization of the cell membrane, the opposite of what happens systemically, which then activates voltage-gated calcium Ca2+ channels, causing an influx of calcium into the cell. As we know, increased intracellular calcium triggers smooth muscle contraction and thus vasoconstriction in the pulmonary arterioles. So complete different downstream effects of hypoxia on ion channels, leading to opposite results compared to systemic vessels.
That's really remarkable, but why? Why on earth would the pulmonary vessels constrict when oxygen is low? It seems totally counterproductive if the goal of the lungs is to pick up oxygen. Why restrict blood flow there?
This pulmonary vasoconstriction, HPV, actually serves a very important and quite clever short-term adaptive purpose, but only when the hypoxia is localized to a specific region of the lung. Imagine, for example, you have pneumonia affecting just one lobe or maybe a mucus plug blocking the airway to one segment. That part of the lung becomes poorly ventilated and therefore hypoxic.
Okay.
By constricting the blood vessels specifically in that poorly ventilated low oxygen area, the body automatically shunts blood flow away from that useless segment and redirects it towards the better ventilated portions of the lung where gas exchange is still happening effectively. This process optimizes the matching of ventilation, airflow to perfusion, blood flow, often called VQ matching, trying to make the best use of the functioning lung tissue and minimize the amount of deoxygenated blood returning to the heart.
Ah, okay, that makes sense as an adaptation for localized lung problems. It sends the blood where the oxygen is. But what happens if the hypoxia is widespread throughout both lungs, like at high altitude or in severe diffuse lung disease?
That's where this localized adaptive mechanism becomes decidedly maladaptive. If the hypoxia is global, affecting the entire lung, then this HPV response happens everywhere. It leads to generalized pulmonary vasoconstriction, significantly increasing the overall resistance to blood flow through the entire pulmonary circulation.
And the consequence of that?
The major negative consequence is a big increase in pulmonary artery pressure, pulmonary hypertension, and increased afterload on the right ventricle of the heart. The right ventricle has to work much, much harder to pump blood into those constricted pulmonary vessels. Over time, this can lead to right ventricular strain, enlargement, hypertrophy, and eventually right heart failure, a condition called cor pulmonale. So a mechanism designed to help locally can be harmful globally.
What about the effects of hypoxia on the central nervous system, the brain? This seems like it would be particularly vulnerable.
The central nervous system, particularly the higher cortical centers responsible for thought and judgment, is indeed highly sensitive to oxygen levels, and the changes caused by hypoxia are critically important clinically.
What are the immediate signs you might see if someone becomes acutely hypoxic, affecting their brain function?
Acute hypoxia can rapidly cause impaired judgment, difficulty with concentration and complex tasks, and often motor and coordination clumsiness. The sources interestingly note that clinically, the outer presentation of acute hypoxia can sometimes resemble acute alcohol intoxication.
That's a useful comparison. And at high altitudes, where the inspired oxygen level is lower, even if the lungs are healthy.
High-altitude illness is a classic example of the body's response to this reduced ambient oxygen. The constellation of symptoms often includes headache, which the sources attribute, at least in part, to cerebral vasodilation, the blood vessels in the brain widening, likely as a compensatory mechanism to try and increase blood flow to maintain oxygen delivery. Other common symptoms include gastrointestinal upset, nausea, vomiting, dizziness, insomnia despite feeling tired, fatigue, and somnolence or drowsiness.
And there are also more severe, even dangerous forms of high-altitude illness mentioned in the sources.
Yes, unfortunately. High-altitude pulmonary edema, or HAPE, is a serious complication we touched upon. It's caused primarily by that exaggerated or uneven hypoxic pulmonary vasoconstriction, leading to high pressures in the pulmonary capillaries and leakage of fluid into the lung air spaces, edema. The sources point out how HAPE itself worsens the underlying hypoxia, creating a dangerous, vicious cycle that further promotes pulmonary vasoconstriction.
And the brain equivalent.
High-altitude cerebral edema, or HACE, is a rarer but potentially fatal condition characterized by severe headache, confusion, ataxia, loss of coordination, and often papillema, swelling of the optic nerve visible on eye exam, which can rapidly progress to coma due to swelling within the confined space of the skull. It's a neurological emergency.
And in very severe prolonged hypoxia, regardless of the cause, what ultimately happens related to the brain that leads to death?
As hypoxia becomes profound and sustained, it eventually begins to affect the vital regulatory centers located in the brainstem, the lower part of the brain that controls fundamental autonomic functions like breathing and heart rate. The sources state that death in these severe hypoxic states is most often due to respiratory failure, as the brainstem's respiratory control center falters and breathing ceases.
Finally, let's briefly look at the effects of hypoxia on the cardiovascular system more broadly, beyond just the pulmonary vessels. How does the heart and systemic circulation react?
Well, acute hypoxia triggers the chemoreceptor reflex arc. Sensors in the carotid bodies and aorta detect low oxygen. This stimulation generally leads to systemic venoconstriction, a tightening of the veins, which helps to mobilize blood volume from the periphery back towards the heart, and simultaneously, as we discussed, systemic arterial vasodilation in many beds, which helps to reduce the resistance the heart has to pump against to get blood out to the tissues.
And what about the heart muscle itself? Does hypoxia affect its ability to contract its myocardial contractility?
Yes, there's an interesting biphasic response described. With acute, sudden drops in oxygen, there's often a transient increase in myocardial contractility. The heart muscle initially contracts a bit more forcefully, likely mediated by sympathetic nervous system activation, trying to boost cardiac output. However, the sources highlight that this initial boost is typically followed by depressed myocardial contractility with more prolonged or severe hypoxia. The heart muscle itself begins to weaken and function less effectively when its own oxygen supply becomes inadequate for an extended period. It can't sustain that increased effort without enough fuel.
Wow, that was an incredibly detailed journey through the body's intricate response to low oxygen, covering everything from the molecular machinery within individual cells scrambling to make energy without oxygen, to that fascinatingly different location-dependent reaction of blood vessels and the widespread complex effects on crucial organs like the brain and the heart.
It really underscores the fundamental dependence of virtually all life processes on adequate oxygen delivery, and the complex, elegant, and sometimes paradoxically self-defeating ways the body attempts to cope when that critical delivery system is compromised. Understanding these layered responses, from HI1 up to organ system failure, is absolutely key to grasping the pathophysiology of so many disease states.
We've covered so much ground in this deep dive today. We've thoroughly unpacked the nuances of hemoptysis, realizing that coughing up blood is a symptom with that remarkably wide range of potential causes, from something as simple as bronchitis to serious infections like TB, vascular issues, and cancers. And we've highlighted that critical insight from the sources. The real immediate danger in massive bleeding is often airway obstruction and asphyxiation, not necessarily bleeding out volume-wise.
Exactly. And then we explored the intricate physiological cascade that unfolds during hypoxia, seeing how cells desperately shift their energy production strategies, how a master genetic regulator like HIF1 kicks in to orchestrate longer-term adaptations aimed at survival and improving oxygen delivery, like making more red blood cells and blood vessels. And we saw how vital organ systems like the brain and heart react, sometimes with initial compensatory mechanisms that are then followed by dysfunction or failure if the hypoxia persists or is too severe.
It truly highlights the incredible interconnectedness of the cardiorespiratory system and the profound complexity that lies just beneath the surface of seemingly simple symptoms or physiological states. To truly master these concepts like an elite professional, you absolutely have to understand these underlying mechanisms and pathways that the sources lay out.
Absolutely. The level of detail provided in the source material gives us that necessary foundation to build that deeper, more expert understanding. It's not
Hmm.
just about recognizing the symptom, it's about knowing the physiology inside out.
Thinking about all this, how the body has these incredibly specific molecular sensors like HI1 and these complex gene regulation pathways just to try and survive with less oxygen, and especially how that very same stimulus, low oxygen, tells blood vessels in your legs or your brain to open up, but simultaneously tells the blood vessels in your lungs to squeeze shut.
Yes, that differential response is fascinating, isn't it?
What does that starkly different vascular response really tell us about the fundamental biological programming, maybe even the evolutionary history in different parts of our circulatory system? And pushing that thought further, what might that inherent biological difference, the specific channels and signals involved in HPV versus systemic vasodilation, suggest about potential future therapeutic strategies? Could we perhaps selectively target or override those specific localized responses to better treat conditions like pulmonary hypertension, or maybe even find ways to induce dilation in the lungs when needed, or selectively improve blood flow in other ischemic tissues?
That's an excellent and profound question to end on. That differential vascular response is indeed one of the most striking and actively researched paradoxes in vascular physiology. It strongly suggests deep, tissue-specific evolutionary adaptations and distinct underlying molecular machinery. Further research aimed at precisely dissecting the unique molecular triggers, the specific ion channels, signaling pathways, maybe even metabolic sensors that cause pulmonary vessels to constrict while systemic vessels dilate in response to hypoxia could absolutely unlock entirely new therapeutic approaches. Imagine drugs that could specifically block HPV without causing systemic vasodilation, or vice versa. It's a huge area of potential innovation, rooted directly in understanding that fundamental physiological difference we discussed.
It really gives you a lot to ponder beyond just the immediate clinical management, thinking about the basic science implications.
It certainly does. The rabbit hole of physiology, as you dig deeper into the source material like this, is always deeper and more fascinating than it first appears. There's always another layer.
Well, thank you for joining us on this very deep dive exploring the complexities of hemoptysis and the body's intricate journey through hypoxia. We hope this exploration, drawing heavily on the detailed source material, leaves you feeling significantly more informed and equipped to understand these critical medical topics with that sought-after expert insight.
It was a real pleasure. Delving into the source material at this level of detail is truly illuminating and reinforces just how amazing and sometimes precarious our physiology is.
Until our next deep dive.